This podcast is for educational purposes only. Please consult your doctor before changing any medical care. This information, products, or comments contained within this podcast is not approved by the FDA for the treatment or diagnosis of any disease. Although we attempt to keep the information up to date and current, we cannot guarantee the information is up to date at the time of this recording. Individual results will vary. No one should expect the outcomes or results mentioned or described in this podcast. Health shares do not constitute health insurance and do not provide a guarantee to pay for your medical bills. Please consult your broker, general counsel, and/or doctor before changing your healthcare plan. Envita and Envita Health makes no guarantees for outcomes and results. Thank you for joining us. I'm Dr. Dino Prato, founder and CEO of Envita Medical Center, here with Dr. John Oertle. And at these long days we have, and then we get a chance to come on and do a case history. So we always apologize if we look tired because we're not building podcasts. We're seeing, in the middle of the operations of Envita, but we want to share these because we think that these cases are helpful for people, patients, other doctors to see the approaches that we use here at Envita. So today we're going to cover a prostate cancer was pretty widespread, and you can see that there's some really unique things that part of our algorithm picked up in care. So Dr. John Oertle, thank you for joining me, Chief, one of the lead physicians in our team here at Envita, and works with me on the R&D, and he's going to go over the case with us, and I'm going to share as well as we go through the case. So let's bring this up. And Dr. Oertle, here we are for another presentation. I know you've had a very long day yourself. So go ahead and take us through this prostate cancer case and some of the key aspects to it. And then I'll jump in as well. And hopefully this information will help our patients, other doctors, and those that are watching.
Absolutely. Gladly. Well, in this case, this was I want to say too, anytime we're discussing these cases, these are people's lives. I just love this, that it's not just an academic exercise and looking at, slides and numbers on a screen. It's actually people's lives. And what a gift to be able to actually, share these cases, because these are patients. These are people that we love and we care for at Envita. And it's just a great joy for our team to all see these. And I hope it's a joy for you to be able to hear about this as well. But this was a 70-year-old man who came to Envita, and he was diagnosed with adenocarcinoma of the prostate. Now, many times people say, well, prostate cancer, you can outlive prostate cancer. Don't worry about prostate cancer because you're going to outlive it. That's be very cautious with anybody that tells you that. You want to be able to treat it really judiciously as far as that goes, and really understand what kind of prostate cancer you have and what's going on with that, and looking at how it's metabolizing, looking at root causes, what's causing it to be able to move the way that it does. Unfortunately, in this cancer case, prostate cancer had moved everywhere. So prostate many times metastasizes to the bones. And this, when we say bone involvement, we'll show you a picture of just how involved the bones were. But he was being recommended right then more chemotherapy, just what standard care provides. The standard of care model is chemotherapy, high dose, high maximum therapeutic dose chemotherapies, which oftentimes don't work very well at all with prostate cancer anyways, radiation therapy, and then ADT, or androgen deprivation therapy. Essentially, this can be really severe as far as this goes and cause a lot of side effects with men, causing them to be able to feel almost castrated, feeling like they don't have fatigue, or they have fatigue, and they have a lot of other side effects that are just not making them feel like a man with the energy and brain function.
Yeah, or any of that, right? The from everything from libido to erectile dysfunction, all of that comes on board. And the important thing to understand is that testosterone, or those androgens, are important to your cardiovascular system, your mental, your body. So it's not just the sexual function that's diminished when you're on these androgen blockers, but it's important to understand that if those are feeding the cancer, in the interim model, you can, and we'll go through the case and show more about how to do precision when we have this type of androgen going on.
Excellent.
So here you have the PSA.
Okay, so this is, many men are familiar with the PSA. So this is where again, PSA is a good measure of prostate health. It's not everything, but it certainly is a good measure. This is through the roof, 1780. Any man that's tracking and monitoring the PSA because of looking at benign prostate hypertrophy or maybe prostatitis, or it's maybe a little elevated, this is literally, it is through the roof. Not saying that this is the worst we've ever seen, but
No.
it's high, very, very elevated for this gentleman.
One would say beyond suspicious, right? That is a very high number.
Yeah.
All right, let's continue here. So let's
All
take
right.
a look at the CT.
We also look at a couple of other biomarkers as well. One of those biomarkers that we look at is called CT-free DNA. This is DNA that's in a cancer cell. So this is cancerous DNA that's now floating around in the bloodstream. The reason why we look at this is because this should not be there. When we have two of these were very high for percentage allele mutations, 68.8 and 22.5. This leads to a very difficult prognosis. So anybody, so many times oncologists are not trained in molecular, even looking at these actual molecules in molecular oncology. If you do find somebody with molecular oncology training, they'll say this is a very poor prognosis for somebody that has a KDM6 at 68.8 allele mutation frequency.
Yeah, and so just so you understand, we run much more than this, but again, for our slides and these presentations, we just try to highlight what we think are some of the key markers of interest in the genomic screening. Envita does in its initial intake, we're screening all the genomics, immunotherapy, adjuvants. We're looking at all the causative agents of the cancer, so many things that go into our algorithm of care. And I just want to point that out. So here is the image. It says a lot. So
what you're actually seeing here is it really is, just look at the very the farthest right image, because this is the over a course of time. So this is contrast material of the bones. This is a scintigraph, or a bone scan, commonly called. And what you see is that all that metabolic activity is going right directly to the bones. Where you see dark spots is where you have cancer. And
so these are
just
active
to give you an
metabolic.
idea, this is very, very severe.
Yeah, active metabolic areas with that high PSA, this strong bone involvement, you have a very serious prostate cancer case here. And I guess you can see that here on the image. So
you see it in the skull. The concern here is that anywhere you have bone cancer, or bone metastases, you have weakness of the bones. So this gentleman in the risk have fractures, pain, bone metastases have significant amount of pain, and just a very poor prognosis, as the molecular data would suggest.
Yeah, not just the molecular data. Here you have the imaging that's like
you see it.
very strong. And the reason I say that is because it's really nice to see. Okay, so good to see the before, and then when we read through the reports, you can also see how they're responding here to care. So let's go on.
Okay, so we prescribed a 12-week treatment plan for him. This guy, he's recent at Envita as well. We gave him GTF chemotherapy with the chemotherapy docetaxel. So he actually had a chemotherapy that was what was suggestive to be able to be supportive for him is docetaxel. This was a genetically fractionated dosage of chemotherapy. So we're not just giving chemotherapy, we're giving it at a low dose where it's not causing harm to the body. Many times oncologists will give these doses of, like for instance, docetaxel at a high level of dosage. And what this does is that it creates more side effects, and it also suppresses immunity, which we'll see in his case is a critical factor as well to be able to make sure that we're actually supporting this gentleman.
Let me explain this, because sometimes patients might ask. So the other thing that's unique about genetically targeted fractionated chemo is that we'll use several different metabolic markers in oncology to guide the treatment. So when we're honing the cancer cell, because the idea is not just to have the right target and give it in a lower dose, to make sure that it gets more to the cancer cell and less to the body. So we will use different components to help us. For example, glucose and insulin is a big feeder potentially for some cancers. Another one is inflammation. Another one is lack of oxygen. So these different metabolic markers are used to time the delivery of medicine as an adjuvant to get it directly. So we use nanoparticle delivery that goes more, and because there's so much bone activity and inflammation in this case, because remember those bone scans, right? They're also going to give you not just spread information. They can also tell you there's more activity happening in those regions, right? So we're going to hone in the care and use metabolic. Now understand that cancer is a metabolic disease. So for it to be ignored, where it is in all of standard oncology, to be ignored in treatment is wrong. And understanding that there is a metabolic factors, when you understand that, that also helps you deliver a better treatment plan, a more precise treatment plan. So, and then continue here. You have your
Well, I have this, the low dose Zytiga. So again, I talked about that androgen deprivation therapy where you're blocking testosterone so that it doesn't actually have the effects that it has on your body. It doesn't have it essentially gives a man a chemical castration. We used a low dose Zytiga. Okay. What did this mean? This meant that we got the ability to be able to actually have the adjuvants, the chemotherapy working in concert with those metabolic support of the body. We used a low dose hormonal blockade to be able to make sure that this gentleman could actually, we didn't want to just chemically castrate him. We don't do that to our men. This is where it's really important that this gentleman has a quality of life. That even this is that, we want him to have good energy. Testosterone serves a function within the body. So when we dose it correctly, now we see that it's actually starting to work. We actually pair this with his meal as well because our doctors know their diet and give recommendations on diet. So medications work with various diet. Cancer works with various diets as well. But we see this with a low-fat meal to make sure that it gets proper absorption. We also see that this is paired with adjuvant treatments. This is really important. We talk about adjuvant treatments being phytotherapeutic treatments. Prostate cancers on a whole work incredibly well with various phytotherapeutic agents. The problem that I see, though, is that when people go to an integrative doctor and they're just prescribed a single phytotherapy or a natural IV, we're not actually doing precision targeting. And I will tell you that it's really a critical thing that they respond very well to these different phytotherapeutic and natural agents, but it needs to be the right phytotherapeutic agents. And for this gentleman, we were able to actually run his biomarkers and actually find the right adjuvant targets to be able to enhance the immune system support, enhance the chemotherapeutic support, and to be able to actually support the actual those biomarkers within the actual gentleman's cancer.
Now, that's important because what you have to realize here is the adjuvants are playing a multiple role in this particular case. One, they're working on the targets to adjuvantly support the chemotherapeutic or the kill of the cancer, supporting the immune system. But then you're going after causative agents, which are critical here to the immune system. So if you ignore these, you say, well, lead is high, but the lead is where does lead store itself? The bone, right? It's an area of storage of cancer. So understanding that you have immune suppression essentially at the osteo, of the bones, right, in the periosteum and around the areas of bone, particularly in the periosteum where you have the immune activity that can occur in that region. We know that because of our history with treating osteosarcomas and other cancers. Those areas, when you have the lead, plays a role in care. So here, this is being removed from the body. Then these viruses
we identified that it was there.
Yeah.
This is really important because these are aspects where you want good diagnostic criteria to be able to look at where are you going with the patient to be able to make sure that you're able to treat those causes and supporting those mechanisms that you want to be able to continue to enhance. When it comes to the ability to be able to support immunity, we want to remove those offensive agents out so that the body actually can be supported and actually can start to heal. The tissues can start to heal. And so we started doing this with this gentleman and started removing the lead. We also found viruses and bacterial infections, chronic viral and chronic bacterial infections. Now, these chronic viruses and chronic bacterial infections, they are carcinogenic, meaning that they actually lead to cancer.
That's right.
You and I had published a paper a number of years ago. The novel idea about actually looking at peer-reviewed articles and journal research to be able to see all the infections that are leading to the infectious causes of cancer. And it's a really critical thing that if it's in a single tissue, this is where it's similar. Many people know about, say, for instance, HPV and cervical cancer. Okay. Mm-hmm. HPV and cervical cancer. HPV is a virus that causes cervical cancer. And yet it does cause cervical cancer, but it also has been found that if it's in your buccal mucosa, that it can cause head and neck and tongue cancers. Really important. So it's where the virus is at, that it's getting into the tissue, causing that DNA mutation to eventually cause to trigger cancerous activity.
This is really important, and I want to add another component which we didn't show here, but one of the genomic screenings we do are for mRNA, which are precursors, right? So these are genetic information, epigenetic data that's telling us this is feeding the cancer before the genetic changes. I don't want to make it too complicated. And you have this whole movement in integrative medicine, which we explored about almost 7-8 years ago, where doctors are using this SOT, right? Oligo, right? Nucleotide, so forth therapy to silence the mRNA specifically. The problem with that in our clinical experience is we don't see the same results that we do with our precision care. And the reason I want to point that out here is that these adjuvants are acting to silence mRNA, which is very big for prostate and most cancers, but it's also acting to help with the immune system in the anti-infectious care. And it's also helping in recovering of the body during chelation therapy, right? And it's also helping to act as a adjuvant into the proper chemotherapy. So the complexity here, where somebody would say, well, I'm going to do alternative medicine, you're missing precision. Because when you do precision, you can dial in the right integrative agents that support the conventional care and the best targeting method to give the best results. So here, you can see, when you see this cancer so widespread in the bone and throughout the body, there's other things going on. It's more complicated than just prostate cancer. There's infectious disease, there's heavy metal toxicity, particularly immunosuppressive on both fronts, and you have a hormonal receptive cancer. So understand that if you go a conventional route, you maybe get hormonal therapy like Lupron, very high dose chemo, but you're not getting all of this other care, and maybe radiotherapy. I don't know where you would start when you have that kind of widespread bone. You couldn't give that much radiation to the body. That is the importance of precision. I want to point out how this precision makes all the difference. And then here, this is really powerful. And of course, we don't have the images yet, but if we do, we can update it. But you can see here the PSA going from 1780 all the way to 10.8. I mean, that's right through the course of care. Knockdown, the PSA knockdown, patient's quality of life, which we don't have, is amazing, right? The patient is great quality of life. That's the most important thing. The quality of life of the patient is tremendously improved. And here you can see the great success in using precision and integrative care with John or Dr. Oertle. Before I take this slide down, anything you want to share before I move this slide out? Anything?
Yeah, I just have to say, I mean, it's the brilliance and the beauty of precision care to be able to see that this is in the conventional model, this is a very challenging case. And to be able to see it responding in this kind of way is nothing short of a miracle. Now, what I want to say is that it's interesting too, because you'll see many times, oftentimes you have, he'll go back home and maybe meet with his general oncologist, be able to say, well, this is an amazing result, or this is incredible. Many times these oncologists say, well, you just got lucky. Good for you. They just got lucky.
Spontaneous remission. Yeah. Listen,
and it's a really critical thing that, again, I always say this because it's a really critical thing when I see something in medicine, because I want to also understand that I'm humble enough to know that I don't know everything. But when we see really amazing things, we look at it, we research, we look into the actual, how does this play a role in the patient's case, and how does it play a role in the context of, we've been around for 23 years, so we've seen a lot of integrative. We've seen the best of standard oncology. We travel around the world looking at this. But when there's something novel and new that actually is, that there's something worthwhile that somebody's doing somewhere in the world, we want to be able to be humble enough to say, I think this could work. And it's really critical. We tried SOT in the past, and we brought it into our Hermosillo facility internationally. It just didn't have the same results that these other therapies have. So I want to be able to be humble enough, but I do see that it's kind of wild to me when we have oncologists, they say, well, you just got lucky, and don't look at it deeper to be able to say this can't just be a case of, we just get very lucky, Dr. Prado. You and I, we're batting really well. This is based upon a lot of data, a lot of research, a lot of the hard work to be able to serve people and go to bat for people in really difficult cases.
Well, here's the interesting thing. No doctor has all the wisdom on medicine, right? There's not one doctor has all the wisdom on medicine. We understand that. And we're able to do this work by the grace of God. So I can't tell you the number of times, that you hear spontaneous remission, but you can't have this many every month across complex cancers like we see at Envita, one after the other of spontaneous improvement, or how did that happen? And as time goes on, we'll continue to share more case histories. It helps people to see that precision oncology is the future. And we want to encourage that, champion that. Why? Because we believe by the grace of God, people are to live a long, healthy life. Really are. And in the gifting we've been given in medicine, and by the technology we've been given, and innovation and creativity in the area of oncology, we want to see people live longer, or be able to accomplish the missions of their life, right? And so that's why this technology not only needs to remain as an option to patients, but needs to become an important part of their care going forward, because it gives them opportunities. You would have never had this combination in a standard setting. That never happened. And the doctors say, well, that doesn't matter. That doesn't matter. That's because the training is missing to understand these important keynotes that we've learned, that if you don't treat that lead, you don't get rid of that infection, you don't reestablish the immune system, you don't use the right microdose, it will return or come back faster, not giving you the length of quality of life, because it'll become more and more resistant over time. So anyways, this was a great case to share with you. John, Dr. Oertle, thanks for coming on again with me today. Again, a busy day. We're busy. So if we look like a little bit tired, we apologize. We're trying to get as many good case histories so that patients can follow the work at Envita and get good hope from good medicine, right? From the technology, not from anything else, but from the technology and our patients. So let me tell you how important that is. And I just want to say, may the Lord bless you all on your journey to healing. Hopefully this was helpful. Thank you for joining me again, Dr. Oertle, and for all of you, thanks for watching. If you have any questions about your specific case, I can't reiterate this enough. Contact or speak to one of our patient care coordinators. Everybody is different. Their needs are different, but this just gives you an idea of the way we approach cases, so you have a better understanding of Envita. So again, God bless all of you. May the Lord bless you on your journey to healing, and thank you for joining us.